It is 10:45 and our break is now over. I would like to welcome everybody back and welcome back to my spectators. Before we begin, I'm going to give a few instructions. The speaker list page. You should be at this screen with a go-to discussion link. Please click on that link now. You will see that your MCQs, your answers, and your performance will appear. Case numbers, question numbers, and your response along with the group response. The answers in green are the correct answers. And before we just begin our discussion, let me turn everything over. And let me remind you, please, Dr. Viswanathan does give a very thorough discussion. But should you have a question, please use your question panel. Include both the case number and the question number. And I'd ask that you be very specific. Our time is limited. And let me go ahead and set things up for him to begin. And I'll be just 1 second, get my screens together. Sir, you have been now made the presenter. You should have everything you need. Is everything available to you?
Yes, it is. Thank you, Ruth.
Okay, great. Thank you, sir.
Well, hello, everyone. Good morning to everyone. We're going to start the discussion now for the imaging anatomy neuro portion. And it's a lovely Sunday morning, and I can think of nothing better to do than go over some neuroanatomy. So with that, we can get started. The first question says, which of the following arrows is pointing to the central sulcus? And the correct answer is C. And it's very important to identify the central sulcus because especially surgeons, when they operate on peri-Rolandic tumors and for other clinical purposes, it's very important to know the anatomy. So how then can we identify it? Well, probably the first way to know is that the motor strip is always thicker than the sensory strip. So on this axial image, you see that this is thicker than, this gyrus is thicker than the one immediately posteriorly. Also note that there are these convex posterior concavities in the motor strip itself, one of these which we'll talk about in a few moments. Another way to identify the central sulcus is to remember that the superior frontal sulcus, which is this sulcus, which lies just lateral to the superior frontal gyrus, so the superior frontal sulcus intersects the precentral sulcus, and then the gyrus immediately posterior will be the motor strip, because then you know that this is the central sulcus. And the last way you can identify it is if you see this, the post-central sulcus, it sort of terminates in this Y-shaped configuration, this sort of inverted Y, and then therefore anteriorly you know that this is C is again going to be the central sulcus. So good, the majority of the people got that question correctly. And it's also actually nice to be able to identify the central sulcus on the sagittal projection, and sometimes I use this as well. So here on the sagittal image in the midline, so you know that this is the corpus callosum. The sulcus immediately adjacent to that is the callosal sulcus. Here is then the cingulate gyrus, which courses posteriorly, so therefore this is the cingulate sulcus. And if you follow the cingulate sulcus posteriorly, you'll notice that it starts to ascend here. And this, as it ascends, that's called the marginal ramus. And the sulcus immediately anteriorly, running sort of obliquely, is the central sulcus. So it's just another way to identify the central sulcus. So hopefully we're all clear on that. And then we'll get to the second question then. So which of the following areas would be neurologically affected by a lesion shown in this arrow? And the correct answer is actually the contralateral hand. And this gyrus, so we know that this is the motor strip, and we should know that the organization of the homunculus from medial to lateral. Remember, medially you have the foot area, foot, trunk, and then you get into the hand knob, and then as you get more lateral, you're starting to deal with the face and the lips. So this gyrus specifically, when it has this little convex posterior margin, this is actually referred to as the omega gyrus, and that corresponds to the hand knob of the motor strip. And we know that there's a decussation of the corticospinal tracts, so therefore if there was a lesion, be it an infarct, a tumor, or other processes, you would have a lesion that would affect the contralateral hand. So therefore the correct answer is B in this situation. Okay, question 3. Which of the following areas would be neurologically affected by a lesion shown in this arrow? Again, we talked about it. Organization of the homunculus. As you go medially, we're dealing with the foot and trunk, hand knob here, and then again laterally, face, lips, etc. So this area and the medial portion of the motor strip, also known as the paracentral lobule. So if you had a lesion here, you would be affecting the contralateral foot. So that's kind of an important concept to remind ourselves. And then the last question in case 1 is, what is being pointed out in this arrow? And is it the scalp, the diploid, dura mater, or subarachnoid space? And notice that this is a T1 weighted image. You see that the diploid contains the marrow. And we should always look for the normal marrow signal, typically T1 bright, T1 hyperintense. So the correct answer in this case is the diploid. And it's always important to look at the marrow signal to make sure that it's not being replaced by tumor or other processes. And it's very important to identify that on our T1 weighted sequences. So moving on to the next question. Which of the following functionally important areas is marked by the arrow, by this arrow, and is it the area for hand control, the visual cortex, Broca's speech area, or the equilibrium center? And that's great. Majority of the people did get this question correctly. So this is the Broca's speech area. Remember, the Broca's area is going to be in the inferior frontal gyrus of the frontal lobe. So here we see the sylvian fissure, and at this location is very typical for where we see Broca's speech area. Of course, it's not a functional MRI where we can actually see bulb-associated activation of the area, but this anatomically does correspond to the area. And also, it's also kind of nice to see on a sagittal T1 weighted sequences. You can also, there's another way to actually help you identify it. So if you go off sagittal, you can see the mandibular condyle here, and what we're seeing is you can notice there's a sort of M-shaped configuration, and a way to identify Broca's areas with this M is that you see this sort of looks like a triangle. That's called the pars triangularis. And then posteriorly, this area near the operculum, which is called the pars opercularis, right in this area is typically the Broca's speech area. And by the way, you know, it's going to be our superior temporal gyrus. In this location is where you're going to have your receptive speech, and then there's a tract, the arcuate fasciculus, which goes like this, and it's sort of Wernicke's to Broca's area. So the correct answer there was C, Broca's speech. Okay, getting into some vascular anatomy on case 3. Which of the following segments of the middle cerebral artery is being pointed out the arrow? And the correct answer is the M2 segment here. So remember that the middle cerebral artery has 4 segments. It's got a horizontal M1 segment, and then as it courses in the sylvian fissure, it's got the insular segment right in the insula, and then as it courses superiorly, it's going to have a opercular segment, M3, and then finally cortical branches. So in this location, we're beyond the horizontal segment, so we're right in the insula, so this is the insular or M2 segment of the MCA. And it's also sort of important to always look at our flovoids in our imaging, which also gets to the point of the next question is, which of the following structure is being pointed out by the arrow? Is it the thalamostriate vein, septal vein, internal cerebral vein, or great vein of Galen. So the correct answer is the internal cerebral vein. Remember that the internal cerebral vein, part of the deep venous system, are these paired veins that course anteriorly from the vein of Galen just at the undersurface of the splenium of the callosum, and then it's going to course anteriorly. And then the other distractors here are the thalamostriate and septal veins. Remember that the thalamostriate and septal veins are going to be more anteriorly. Septal veins run along the course of the septum pellucidum. Thalamostriate veins more laterally. They merge and then they form the internal cerebral vein, which then will, and then the basal vein of Rosenthal will hook in from the ambient cistern, and then you'll see the vein of Galen, etc. So, and also, as I was alluding to earlier, remember to look at the flow voids, whether it's the M2 segment of the MCA, especially on our T2 weighted sequences, which this is, and our just because you don't want to miss the possibility of a thrombus or possibly slow flow or other vascular states. Okay. So the next question is, which of the following structures are the white dots pointed out by the arrows? And that's great. A majority of people got this question correct. It's the perivascular spaces around the lenticulostriate arteries. Remember that the M1 segment has these lateral lenticulostriate arteries that then go into the basal ganglia. And as they do, they're sort of lined by these CSF line spaces, perivascular spaces, and they go into the basal ganglia. So, and it's also important to remember when you see, sometimes these perivascular spaces can get quite large, and they can mimic other conditions. I've seen very large spaces, you know, in different parts of the brain that have been confused with things like tumor. But remember, is it following CSF signal? And that will help you. So look for it to be hyperintense on the T2 weighted sequences. It should suppress on the flare sequence, and then you know that you're dealing with a perivascular space. Okay, the next question is which segment do the of the middle cerebral artery do the lenticulostriate arteries arise from? Is it M1, M2, M3, or M4? Well, the correct answer is the M1 segment. So when we remember that, again, as I mentioned, lenticulostriate vessels lateral will arise from the M1 segment. They then will course and feed the portions of the basal ganglia, and it's actually, when we see a patient who has infarction in this area, sometimes we'll say that this is a perforating vessel infarction, and that just simply means that this is an infarction related to maybe a thrombus that's involving the M1 segment, and therefore you're getting all those lenticulostriate vessels that course from them. And typically when you see an infarct and distribution on your diffusion sequences, sometimes you get a clot that sort of lodges along the walls of the M1 segment of the MCA, and then you get spasm, and those lenticulostriate vessels get affected, and that's why you see infarcts in this distribution. So the correct answer, just getting to the heart of this question, is lenticulostriate arteries arise from that M1 segment. And then the next question, which of the following structures is being pointed out by the arrow? And nearly everyone got this question correctly. This is the third ventricle. Remember that the third ventricle is important to identify because it's a very important structure, and it's also important to note the boundaries of the third ventricle. So notice here the lateral boundaries of the third ventricle are the thalamus, and then here I also have a sagittal heavily T2 weighted sequence. This is a Fiesta sequence, and basically this shows you the third ventricle, and I wanted to allude to two important points on this case. First of all, note that there are some that the third ventricle has important recesses, and this here is the optic chiasm. So then, therefore, this is the chiasmatic recess right here. This is the pituitary infundibulum. You can see the pituitary gland here. So this is the infundibular recess right here. And it's very important to see whether these recesses sort of get ballooned out, which these are a little bit in this case. especially in the setting of hydrocephalus. So actually what you see here is, here's the cerebral aqueduct, and you can see that it's stenosed by this web or band here along its superior aspect, and then when you get a dilation of the third ventricle, these recesses start to get a little bit more ballooned and a little bit more prominent. So there are other recesses around the pineal gland, suprapineal and pineal recesses, that are sort of less important to know, but these are sort of important to know just to identify. And then you can see here, this is the floor of the third ventricle. Sometimes in patients with hydrocephalus, the surgeons will come in and actually make a little hole at the floor of the third ventricle so that there is a separate egress of cerebrospinal fluid. Okay, moving on to case 4. Which of the following arrows is pointing to the structure immediately superior to the olfactory tract? Is it A, B, C, or D? And the correct answer is B. So basically here we have this axial T2-weighted structure, and the heart of this question is basically getting to that the olfactory tract lies in the olfactory sulcus. And if you see here that this gyrus here, which is depicted C, is the gyrus rectus, and slightly more laterally with this sulcus is the olfactory sulcus, so that's why the correct answer is B. And then here is the lateral orbital gyrus. And the olfactory tract lies in the olfactory sulcus. This is actually just pointing to the, D was just pointing to the prechiasmatic nerve, but so that's kind of just the main point again on this question is that the olfactory tract lies in the olfactory sulcus. Correct answer was B. And then here, which of the following structures is being pointed out by the arrow? Is it the nerve, the optic nerve, the chiasm, the optic tract, or the radiation? So this is the optic tract. C is the correct answer. Basically, the optic, remember we have a chiasm, prechiasmatic optic nerves, chiasm, and then this posterolateral course of the optic tract, which then sort of extends into the lateral geniculate body of the thalamus, and then there are separate tracts, remember, the optic radiations, which extend posterior from that through the temporal and parietal lobes, and then into the medial occipital lobe where the visual cortex is. So the correct answer here is C. Remember, it extends posterolaterally from the chiasm. Okay. Which of the following structures is being pointed out by the arrow? Is it the insula, caudate, radiation, or I'm sorry, insula, caudate, amygdala, optic radiation? And the correct answer is the amygdala, C. Remember that the amygdala is part of the limbic system, which controls emotions and feelings, all that kind of stuff. And it's a gray matter structure, and the way to sort of identify it with some reproducibility is that it'll be just anterior to the temporal horn of the lateral ventricle. And if you look at your T1 weighted sequences, sometimes if you do the volumetric 3D, the MP-RACE sequence, you can see the amygdala, actually this gray matter structure, with a little bit more clarity. But this anatomic relationship is consistent, just anterior to that temporal horn. So the correct answer was C there, amygdala. Okay, which of the following structures is being pointed out by the arrow? And is it the interpeduncular cistern, cerebral aqueduct, fourth ventricle, or the suprasellar cistern? Well, this is specifically pointing to the interpeduncular cistern. No, there are two cerebral peduncles, and it's between the two cerebral peduncles, so this has to be the interpeduncular cistern. And it looks like almost everyone got that question, so that's great. And the next question is, which of the following cranial nerves has its nuclei being pointed out by the arrow? Is it cranial nerve 3, 4, 5, or 6? So the correct answer is actually cranial nerve 3. Remember that the oculomotor nerve will actually emanate, it has two paired nuclei at the level of the superior colliculus, right just anterior to the periaqueductal gray. And the oculomotor nerve then extends from the interpeduncular cistern, and as it emanates, it courses out, remember, between the posterior cerebral artery and the superior cerebellar artery. So you can get vascular compression from aneurysms, etc., in that location, and then it then courses anteriorly into the roof of the cavernous sinus, and then extends further anteriorly via the supraorbital fissure, where it basically supplies all of the rectus muscles aside from the lateral rectus and the superior oblique. We'll get to the superior oblique in a moment, and it'll sort of then also supply innervation to the levator palpebrae, and therefore if patients have issues with oculomotor nerve, they can get ptosis. It's also responsible for sympathetic innervation. So the main point here is that the oculomotor nuclei arises from just anterior to the periaqueductal gray in the midbrain, and then courses anteriorly. The other important point I wanted to quickly mention is that the oculomotor nerve, as it travels, just courses inferiorly to the posterior communicating artery. And remember that if you have aneurysms of the PCOM, that's another way that you can get that the third nerve can be affected. Okay, moving on. As I mentioned, as I promised about the fourth cranial nerve, the next question is, which of the following cranial nerve exits the brain in the region pointed out by the arrows? 3, 4, 5, or 6? About a mixed 50-50 on this one. So basically, the trochlear nerve lies at the level of the nucleus lies at the level of the inferior colliculus, and then it actually courses. It sort of has this decussation where such that it extends this way, and you have a it crosses over in the superior medullary velum, and then it courses anteriorly in this cistern is the ambient cistern, and then again it too courses between the PCA and the SCA, so posterior cerebral and superior cerebellar, just under the oculomotor. It too will extend into the cavernous sinus just below the third nerve, extends into the superior orbital fissure, and then remember it will supply the superior oblique muscle. So, and recently we had a case of a patient with a trochlear schwannoma, and in the heavily T2-weighted sequence you could see expansion of the nerve on our axial T2-weighted sequence right at that ambient cistern. So it's an important relationship to remember. I'm sorry, the next question is, which of the following is the cistern being pointed out by the arrow? Is it the cisterna magna? Is it the interpeduncular cistern or the ambient cistern? The correct answer is A, the ambient cistern. And we sort of talked about the trochlear nerve coursing in that location. Interpeduncular cistern we talked about before, between the cerebral peduncles, and cisterna magna is going to be in the posterior fossa. Okay, next question is, which of the following structures being pointed out by the arrow? Is it the chiasm, the dorsum sella, the pituitary gland itself, or is it the suprasellar cistern? So this is actually the dorsum of the sella. The correct answer here is B. So this little dot here is the pituitary infundibulum. And you can actually, so this is that posterior wall of the sella, and this then is the dorsum of the sella. And then the next question is pretty straightforward. What is being pointed out by the arrow? And it's the vermis, or portions of the vermis. And you can identify that also in your sagittal sequences. Remember, fourth ventricle, choroid plexus. You do have a tuft of it inferiorly, but that's not really being pointed out. Occipital lobes, obviously not. Uncus is the medial temporal tip. So the correct answer there is A. Nearly everyone got that question. Okay. Which of the next case 6 is, which of the following arrows is being pointed at the Meckel's cave? Is it A, B, C, or D? So the correct answer is B. Remember that the Meckel's cave is this CSF line space, which is lined by dura and surrounded by another meningeal layer. And that CSF lined area within the Meckel's cave is actually contiguous with the prepontine cistern located here. And remember that your cisternal, that the fifth cranial nerve emanates from right here at the at the lateral pons in an area called the root entry zone, and then it extends anteriorly into the prepontine cistern. If you have a heavily T2 weighted sequence, you can see the individual fibers of the fifth nerve, V1 and V2, entering into the ganglion there, Gasserian ganglion. But in this, so this is an important, remember, Meckel's cave CSF line space, and then also note that the flow void of the carotid artery lies just medially there. Okay, moving on to case 7. So which of the following locations marked by the arrows contain choroid plexus? So is it A and D, B and E, C and E, or is it everywhere? So remember that the choroid plexus is not present throughout the ventricular system. It is present within the atria and occipital horns of the lateral ventricle. It's present actually in the roof of the third ventricle, which is not depicted here, in the telecharidia. It's also present in the inferior fourth ventricle. So therefore the correct answer here is B, sort of the atria of the lateral ventricle and the inferior fourth ventricle. And it's actually important to know that because when we think about choroid plexus tumors, it actually helps to know that most commonly they either occur in the atria of the lateral ventricles, and we've seen several cases of choroid plexus papillomas, carcinomas at the inferior fourth ventricle. And knowing where they are, knowing where choroid plexus is, will help you obviously can form a differential. So again, choroid plexus B and E, an important point to remember there. Okay, which of the following structures is being pointed out by the arrow? Is it the optic chiasm, fifth maxillary division, olfactory tract, or the third nerve? Well, this is pretty straightforward. This is the optic chiasm that we're seeing on our sagittal T1. Remember, the olfactory tract housing the olfactory sulcus will be in the floor of the anterior cranial fossa towards the midline. We'll get into fifth nerve of the maxillary division, third nerve we talked about already. And so the correct answer is optic chiasm. And by the way, remember when we were talking about our central sulcus anatomy on the sagittal, here's that cingulate, here's a callosal sulcus, here's that cingulate sulcus as it extends posteriorly going into the marginal ramus. This then has to be the central sulcus. So it's a consistent relationship there. Okay, which of the following arrows is being pointed out by the arrow? So this is just getting to the callosal anatomy. Remember that the corpus callosum has 4 parts, this tapered antero-inferior end called the rostrum, then this bend, the genu, and then the larger portion is the body, and then finally the splenium of the callosum. So the correct answer here is C, splenium. The other one, lamina terminalis, by the way, is a structure that forms the anterior boundary of the third ventricle. So that's just that. And let's get into question 4 here. So which of the following structures is being pointed out, which of the following structures is being pointed out by the arrow? Is it the cerebral vein, vein of Galen, vein of Rosenthal, or the straight sinus? So right here, the paired internal cerebral veins, which do run just at the undersurface of the more ventral portion of the splenium, unite and then form the shorter segment vein of Galen, and then remember you have the straight sinus extending posteriorly, the superior sagittal sinus, and then their confluence at the torcula. So this is the correct answer there was the vein of Galen. Okay. Head and neck, everyone's favorite. Which of the following spaces is the lesion marked with an asterisk located? Is it the pharyngeal mucosal space, the submucosal space, parapharyngeal space, or the masticator space? So here's the lesion, and this is located within the parapharyngeal space. Remember, parapharyngeal space predominantly contains, actually essentially only contains parapharyngeal fat, and that's, you can see the contralateral normal fat, and then here is the abnormal soft tissue mass within the right parapharyngeal space. And the next question gets into which of the following lesions can have a primary origin in the parapharyngeal space. Remember, the parapharyngeal space contains predominantly fat, so typically the only primary lesion that you're going to see in this is usually lipomas. But I want to make two additional points. One is, first, you have to know the parapharyngeal space contains fat. Number two is displacement of the parapharyngeal fat can help you identify where a lesion is arising from. So meaning, if this fat is displaced laterally, the lesion must or likely is coming from the pharyngeal mucosal space. If this fat is displaced medially, as in this side, it's likely to be coming from a lesion that's in the deep lobe of the parotid, so it's a parotid space lesion displacing it medially. If it's displaced posteriorly, it's likely a masticator space lesion. If it's displaced anteromedially, you see here's our carotid vessel, so it has to be coming from the carotid space. So the other point again is just note the displacement of the parapharyngeal fat. And then the final point is that most of the lesions, while you can have primary lesions, are actually secondary, meaning they come from elsewhere. And usually they're from deep lobe parotid space lesions, usually pleomorphic adenomas, minor salivary gland tumors that extend into this. So that's an important point in head and neck. And then we'll get into question 9, which of the following structures is identified by the arrow here? Is it the styloid, retromandibular vein, external carotid, or retromandibular artery? So here's the mandibular ramus, and note that there's two vessels that lie posterior to it. The larger one is the vein, the smaller one the artery, and the retromandibular vein lies lateral to the artery, and it helps in identifying the plane of the next question, which is identifying the retromandibular vein helps identify the location of which of the following structures. And a majority of people got this question right. That's the 7th nerve. So the retromandibular vein, remember this, it sort of helps define the plane of that 7th nerve. And the ENT surgeons are always very aware of this relationship when they enter parotid space lesions because they don't want to inadvertently injure the 7th nerve. So we'll get to the next question there. Which of the following paired structures is identified by the arrows? Is it the styloid process, internal maxillary artery, hamulus of the medial pterygoid, superior cornea of hyoid? So the styloid process we're barely seeing here, and actually this location where you see the mandibular ramus and the styloid, here's the stylomandibular gap. Internal maxillary is an ECA, external carotid artery branch, which is not identified by this bony structure. So the correct answer here is the hamulus of the medial pterygoid. You can see the medial and lateral pterygoids here. The superior cornea of the hyoid is not in this location. It will be just slightly more inferiorly. Okay, and then the next question is, looks like our arrow got displaced a little bit, but basically the arrow is supposed to be here. Which of the following structures is being pointed out by the arrow? Is it the maxillary nerve, the Vidian nerve, the ophthalmic nerve, or the masticator nerve? The correct answer is, remember, so this is a coronal T1 post-contrast. You know it's T1 because it contains the marrow here, and the sphenoid is bright. It's post-contrast. You see some of the mucosa is enhancing. And note that the foramen rotundum, which houses the V2, is always sort of in this superior relationship, just like lateral to the sphenoid. And then more medially, inframedially, is actually the area of Vidian's nerve. And then if I had a discussion slide here, basically, remember we talked about the cavernous, we talked about Meckel's cave and then extending into the cavernous sinus. So if you look at our axial images, the V2, will extend. This is foramen rotundum on our axial imaging, containing this abnormally enlarged second cranial nerve extending into the pterygopalatine fossa, which we'll talk about shortly. So this question just got into V2. And then which of the following structures are being pointed out by the arrow? Is it the temporalis, lateral pterygoid, medial pterygoid, or masseter? So this is actually pointing to a small slip of muscle that inserts along the inner surface of the mandible, and this is actually the correct answer is therefore the temporalis muscle. Masseter muscle is located here along the lateral aspect of the mandible, and then lateral pterygoid and medial pterygoid muscle bellies we can see portions of. Okay. So which of the following structures being pointed out by this arrow? Is it the masticator space, superficial temporal space, deep temporal, or paraorbital space? So remember that the masticator space actually, while we typically think of it in this location, remember it does extend superiorly. The temporalis muscle has a large insertion on the calvarium, and this is actually a part of what's called the suprazygomatic masticator space. And it's sort of a large fan-shaped area as it extends to the calvarium. And therefore, while majority of masticator spaces or lesions are usually from odontogenic infections, you can have spread extending superiorly into the suprazygomatic masticator space. And just as another quick point, anytime in head and neck, when you try to identify it or come up with a quick differential for what sort of lesions may be there, think about what lives there. So in the masticator space, you have muscles, so therefore you can have tumors of muscle, sarcomas. You have nerves entering into this location, so schwannomas are common, especially off the masticator nerve, as it extends into the masticator space, which is V3. You have you have bone actually here, mandibular. So you can actually have lesions of bone, primary osseous lesions, osteosarcomas, metastatic lesions. So just as a general rule, think about what lives in the location. Okay, question 2 is, which of the following structures is being pointed out by this arrow? So this is a very important question to know. This is the pterygopalatine fossa. And it's important to know this because it's a very important crossroads in the head and neck. And you should always look for symmetry here. And basically, when you have tumor, we saw earlier the V2 nerve extending into the foramen rotundum, going into the pterygopalatine fossa, and then extending, and then there will be an infraorbital fissure, and then anteriorly an infraorbital foramen. So this sort of area is very important. Always look for symmetry, look for fatty. If there's abnormality, you have to consider the possibility of perineural tumor spread, lymphoma, other processes. Okay. Question 3 is, which of the following traverses the infraorbital fissure? And that again is the maxillary division of the 5th cranial nerve. So remember, V2 goes into foramen rotundum after it emanates from the Meckel's cave, and then to the infraorbital fissure, infraorbital foramen. So you can have tumors extending from the skin surface going back into the skull base. You could have such as a basal cell taking advantage of these different foramina through the infraorbital foramen, infraorbital fissure, into the pterygopalatine fossa, then extending posteriorly via rotundum, getting into the skull base, or through Vidian's canal, etc. So, and we'll get into that on our next series in head and neck. Which of the following structures is being pointed out by the arrow? Is it the body of the sphenoid, greater wing of sphenoid, lesser wing of sphenoid, or zygomatic arch? So this is the greater wing of the sphenoid. And sort of the anterior, the bone that along the anterior aspect of the middle cranial fossa is that. We see portions of the zygomatic arch and the body of the sphenoid there. And then the last question, pretty straightforward, is which of the following structures being pointed out by an arrow? And these are the posterior ethmoid air cells. So that just gets into basic sinus anatomy. Here's a sphenoid sinus. We don't really see portions of the maxillary sinus. And remember that there is this little recess as it extends, which we're not seeing here, but there is a sphenoethmoidal recess extending from the sphenoid to the posterior ethmoid. Okay, case 11. Which of the following structures is being pointed out by the arrow? And so this is the correct answer is C, buccal space. Great. I'm sorry, it looks like the arrow is pointing to it looks like there's a mistake here, but the correct answer should be the buccal space. But notice that So here's a masticator space labeled B. Here's a parotid space, and then D is pointing to portions of the parapharyngeal space, and the buccal space lies just anteriorly to the masticator space. The buccal space, by the way, is also termed the retromaxillary fat pad. Okay, getting into nasopharyngeal anatomy, which of the following structures pointed out by the arrow? Remember, the nasopharynx has two important openings or recesses that you should know about. One is the Rosenmuller fossa, which is A, which we'll get to, and B is this is the eustachian tube, the opening of the eustachian tube, and then so the more anterior of the recesses is the eustachian tube, then you see the torus tubarius, and then the Rosenmuller fossa. So we'll get into that on the next question. Which of the following structures is being pointed out by the arrow? And the correct answer is torus tubarius, which is the cartilaginous end, a portion of this nasopharynx. It lies just posterior to the eustachian tube opening and just anterior to the fossa Rosenmuller, which gets into the next question, I think. And correct, which of the following structures is being pointed out by the arrow? So this is the Rosenmuller fossa, the more posterior of the recesses in the nasopharynx. And it actually serves as the answer to the next question, meaning which of the following arrows is the most common site of origin of nasopharyngeal carcinoma? And again, it is the Rosenmuller fossa. So primary mucosal lesions will efface the fossa Rosenmuller asymmetrically, and you'll see soft tissue extending. In advanced cases of nasopharyngeal tumor, you have to think about where it's going, and that's actually how these lesions are staged. Is it going into the prevertebral musculature? Is it going to the parapharyngeal space, masticator space? Is there bony involvement, etc.? So this important recess is very important because it serves as the origin of nasopharyngeal tumors. Okay. Case 11, so case 12 is which of the following structures are being pointed out by the arrows? Is it the piriform sinuses, vallecula, anterior pharyngeal spaces, or the pharyngeal mucosal space? So this little air space is actually the vallecula, and it's this little tiny air. They're basically these small air spaces behind the base of the tongue, and notice that here this structure is actually the free margin of the epiglottis, and then you see this little medial band of soft tissue. That's actually the median glossoepiglottic ligament. So here glossoepiglottic, so glossoepiglottic ligament, and then these two air spaces on each side of it is actually the vallecula. And then the next question was basically asking which of the following structures is being pointed out by the arrow, and this is the basically the free margin of the epiglottis. You're starting to see portions of those ariepiglottic folds that are forming, and then as you extend inferiorly, you'll see that there will be the piriform sinuses. Okay, case 13 is which of the following potential spaces is being pointed out by the arrow? And that's great. Nearly everyone got this. This is the retropharyngeal space. Remember that it lies, so here's the pharyngeal mucosal space, here's this thin little area of the retropharyngeal space, and then behind that, which contains muscles, is and in front of the vertebrae is the prevertebral space. The retropharyngeal space contains fat. Remember that it's also the site, the lateral retropharyngeal nodes, known as nodes of Rouvier, are important to identify, and it's actually also an important, getting into nasopharyngeal tumor, it's an important location where nasopharyngeal mets go to, those lateral retropharyngeal nodes. And also remember that you can have abscesses in this location, and usually they actually start suppurative nodes in those retropharyngeal nodes and then expand. And it's important to not confuse retropharyngeal abscess with retropharyngeal effusion. You can have a small amount of edema in the retropharyngeal space from inflammatory processes, but it really should not be called an abscess until you see that well-formed rim-enhancing lesion. Okay, which of the following arrows is being pointed out by the arrow? So here is actually between the paraspinal muscles and the sternocleidomastoid muscle, you start to see the posterior cervical space. perivertebral space, or retrocarotid and subcleidomastoid. I'm not actually sure where the subcleidomastoid or retrocarotid space are. They're distractors. So the correct answer there is posterior cervical space. And which of the following potential spaces is being pointed out by the arrow? Again, we talked about this. Prevertebral space, it contains the bone right in front. And you can see the transverse processes, foramen transversarium housing the vertebral artery, and then those two longus colli muscles will be core. Usually when you're dealing
I am aware of the fact that we just lost sound. Can y'all hear me? Can you hear me? Okay, can anybody? Okay, just stay with me for just 1 second and let me see what I can do to help Dr. Viswanathan. So if you'll just bear with me. So hold on, everybody, and I'll be right back with you.
Hello, Ruth?
Dr. Viswanathan, can you hear me?
Yes, I can.
Hello?
I'm sorry. Can you hear me?
Oh, that's okay. Yes, I can hear you now. We lost you. We lost sound, and then we lost your screens for just a second.
Okay, I'm just going to try to get it back. I guess it lost the connection temporarily. Apologize.
Okay.
What should I do? Should I just go back into the webinar?
I'm showing your webinar. I'm showing your images are still up. What we don't have are your questions.
Okay. So then let me, I guess I should log into, hold on one second. So what would you recommend?
If you can log back, you're going to have to log back in to face the core because again, we do have your.
That's fine, but you have my webinar available, correct?
Yeah, you're still up on webinar because we have sound and everything.
Okay, I think we left off at case 13, I believe.
Yes, you're on case 13. Now I'm showing question 4, but could you back up because I think some of them lost sound before then. And if you don't mind, sir, would you back up to question 3? Would that be all right?
Sure, absolutely.
Okay, I'm going to go ahead and mute myself and take care of something else right now, okay?
Okay.
Thank you.
Okay, I apologize, everyone. Lost the connection for a second, but it looks like we're back. So this was, which of the following potential spaces is being pointed out by the arrow? Is it the perivertebral space, vertebral body space, prevertebral space, or the paraspinal space? So again, we talked about briefly, this is the space right in containing the vertebrae and just the structures in front of it. So this is the prevertebral space. We remember just anterior to the prevertebral space is that retropharyngeal space, and then anterior to that is the pharyngeal mucosal space. The prevertebral space will contain those longus colli and capita muscles. Again, houses the vertebral body, some of the foramen transversarium there, housing the vertebral artery. And also remember that a lot of the lesions in the prevertebral space usually are infectious when you have discitis, osteomyelitis, and an epidural and then a prevertebral collection is some of the common things. Sometimes you can get prevertebral abscesses. So the correct answer there was C. Which of the following potential spaces is being pointed out by the arrow? And this is the, is it the perivertebral space, vertebral body space, postvertebral space, or the paraspinal space? This is actually the exact answer to this, the paraspinal component of the perivertebral space. So perivertebral space is sort of a collective term containing both the prevertebral and the paraspinal space. And this, the deep paraspinal musculature, is what's contained within the paraspinal space. And then the next question is, we talked about which of the following potential spaces is being pointed out by the arrow. Is it the pharyngeal mucosal space, parapharyngeal space, visceral space, or retrohyoid space? The correct answer is the pharyngeal mucosal space. And think about in terms of lesions that arise there, usually you have mucosa, so squamous cell carcinomas, and then you also have lymphoid tissue, so lymphoma would be another possibility. So that, again, we talked about is A. Okay, and now getting into this question is, which of the following structures is being pointed out by the arrow? This is the genioglossus muscle. These are paired muscles along the base, tongue base, which along with the geniohyoid muscle, that sort of help form the base of the tongue. And it's also an important landmark for the next question because it forms the medial boundary of the sublingual space. Hyoglossus muscle is actually this muscle that sort of extends laterally. It's not the salivary gland or piriform sinus. The next question actually says, which of the following arrows points to the sublingual space? So remember that the lateral margin of the genioglossus and it forms the medial boundary of the sublingual space. And then also remember that the floor of the mouth has this muscle sling, which is the mylohyoid muscle. And the mylohyoid forms a lateral boundary. So you can see that between the two structures is where the sublingual space is. So the correct answer here is B. Okay, and then which of the following points to the submandibular space? So now we know that the genioglossus, sublingual space, mylohyoid muscle, and then even more laterally from the mylohyoid to this little band, thin band, is the platysma muscle. And between the mylohyoid and the platysma, you can start to see this portions of the submandibular space. Here's a submandibular gland here. So that's very important. Okay. The next case, question, case 15, which of the following arrows points to the expected location of the vagus nerve? Is it A, B, C, or D? So remember that the vagus nerve comes from the medulla. It actually arises from the pre-olivary sulcus of the medulla, then extends into the skull base at the jugular foramen. Remember that the 9th cranial nerve is in pars nervosa of the jugular foramen, the 10th and 11th vagus and accessory are in the pars vascularis. And then the vagus nerve, what it does is it extends into the carotid space and lies just posterior to the carotid, to the jugular vein and the internal carotid artery. So the vagus nerve is in this location, and actually it's kind of makes sense because when you have lesions of the vagus nerve in this location, such as for instance a glomus vagale, you'll note that the carotid vessels will be displaced anteriorly. So that's also an important, and sometimes you can use that to help you identify where a schwannoma may be, or a vagale. So if the vessels are splayed, you probably have a carotid body tumor. If they're both splayed anteriorly, think about the possibility of a glomus vagale. The next question is, which of the following arrows points to the accessory nerve? Is it A, B, C, or D? And remember that the spinal accessory nerve is going to run in the posterior cervical space. We talked about that before, between the sternocleidomastoid and the paraspinal muscles. The accessory nerve, 11th cranial nerve, is typically, usually you see this nerve injured in radical neck dissections, and then you can see patients with atrophy of sternocleidomastoid and trapezius muscles. But this is a constant relationship as well to remember. And then, which of the following arrows points to the glossopharyngeal nerve? So the glossopharyngeal nerve typically is in the medial aspect of the sublingual space. So here's the sublingual space. and therefore the more medial aspect is is actually where the glossopharyngeal nerve is, as opposed to the hypoglossal nerve. Again, remember that cranial nerve 9 comes from the prealveolar sulcus of the medulla, extends into the pars nervosa at the jugular foramen, and then extends into the tongue, basically. And it's also sort of important to remember that a lot of these nerves typically don't get affected in isolation. Usually these lesions are going to be affected by tumors or lesions in the skull base, and therefore you might have multiple cranial neuropathies rather than an isolated one. And then the hypoglossal nerve will be in the more lateral aspect of the sublingual space. So again, sublingual, here's genioglossus, mylohyoid. The more lateral one is going to be the hypoglossal nerve. And then the final question on case 15 is, which of the following arrows points to the expected location of the vertebral artery? I'm sorry, did I skip one here? Okay, now we got to that. Let me just adjust this. So, and the vertebral artery, which nearly everyone got, is right here in the foramen transversarium. Remember, the vertebral artery has 4 components. It's got a V2 as it originates from the subclavian artery, sometimes can arise from the arch as a variant, but typically from the subclavian. It then runs upwards through the foramen at C6. It extends into the foramen transversarium, runs up several segments, and then it then courses posterolaterally into the extraspinal. So V3, where it sort of extends outside the foramina and then comes back into the intradural portion where it becomes V4. So, so this is where the transverse foramina is of housing the vertebral artery. Okay, case 16 is, which of the following structures is being pointed out by the arrows? So we talked a little bit before about this. Remember that these 2 structures are the aryepiglottic folds, and then the 2 recesses along their posterolateral border are the piriform sinuses. So therefore the correct answer here was B. Vallecula, we talked about those air spaces behind the base of the tongue, bounded sort of along the lateral aspects of the median glossoepiglottic ligament. And then the next question is, which of the following structures is being pointed out by the arrow? And this is the platysma muscle. Remember, mylohyoid is not going to be this because that forms the floor of the mouth. And the platysma muscle is important to note in head and neck because when you have infections of the head and neck, this muscle can get thickened and you'll see subcutaneous edema. And it actually helps to look for the muscle, the platysma, if it's thickened or not, as a sign of some sort of process in the head and neck. Okay, case 17 is lymphadenopathy. Which level lymphadenopathy is present in this image? So just as a quick overview, remember level 1 is going to be submental and submandibular, 1A and 1B. Level 2 are going to be running from the base of the skull to, and you have 2, 3, and 4. From the base of the skull to the inferior margin of the hyoid is level 2. From the hyoid to the lower margin of the cricoid is level 3. And then level 4 is from the lower margin of the cricoid to the clavicle. 5 is actually those posterior cervical space nodes, which we'll see in a few moments. Okay, so where is this node then? Is it a 1 node, 2, 3, or 4? Well, this is going to be below the level of the hyoid. You see it's touching the jugular vein, so this is a level 3 node. And we're basically just above the inferior margin of the cricoid on this image, so therefore this is the level 3 node. The next question is, which level lymphadenopathy is present in this image? Well, so here we're, again, we're from the skull base and we're above the level of the hyoid, and it's touching the jugular vein, so this is a level 2 node. And then as opposed to this question, which level lymphadenopathy is present in this image? Remember, we're between the tongue and the platysmal muscle, which we're starting to see a little bit. So submandibular space, these are 2 nodes in the submandibular space, so these are level 1B nodes. So the correct answer there was A. And then which level lymphadenopathy is pointed out by the arrow? So remember, level 5 nodes are going to be running from, there's 5A and 5B. So 5A extends from basically the skull base and to the inferior margin of the cricoid, and then 5B will be below that. And remember that they're going to be behind the posterior margin of the sternocleidomastoid muscle. So here's the posterior margin of that, so therefore this is a level 5 node. And then the last question is which level lymphadenopathy is being pointed out by the arrow. So this is posterior to the, here's the carotid vessels and jugular vein. Remember, it's not touching the jugular vein, but it's in front of the posterior margin of the sternocleidomastoid. So this is a level 2 node, 2B, because it doesn't touch the jugular vein. So nodal stations are important, especially in head and neck when you stage squamous cell carcinomas. Okay, spine anatomy. Which of the following structures being pointed out by the arrow? Is it the anterior lanoaxial membrane, the apical ligament, tectorial membrane, cruciate ligament, or transverse ligament? So this is the posterior longitudinal ligament, and contiguous with that, as it extends on basically the posterior margin of the clivus, is going to be the tectorial membrane. And you can actually see here this little thin ligament is the apical ligament. So the cruciate ligament, you can see a part of it will, so it's like a cross, so it'll, part of it will lie just deep to the tectorial membrane, but then there'll be two, if you picture it from a posterior approach, you'll see two other ligaments emanating transversely, the transverse ligaments. But the answer to this question is the tectorial membrane. The next question is which ligament is this? And this is the anterior longitudinal ligament. So here's the vertebral body, anterior longitudinal ligament, posterior longitudinal ligament here. And then, you know, when you're looking for signs of ligamentous injury, look for a frank disruption of the ligaments in the setting of trauma to suggest the possibility, in addition to edema on your fluid-sensitive sequences. And then the last question we talked about before, which of the following structures is being pointed out by this arrow? So here's that apical ligament running from the tip of the dens to the base of the clivus there. So that's the apical ligament. Case 19 is a very important point here, is which of the following nerve roots will be affected by a lateral disc protrusion at the level shown. So when you have a lateral disc protrusion, remember that you have protrusions that at the L3, L4, the exiting nerve root is going to be the L3 nerve root, and the traversing nerve root is going to be the L4 nerve root. So if you have a laterally projecting protrusion like in this location, you're going to have radicular symptoms along the course of the L3 nerve root. Which structure is being depicted by this structure? So here's a T1 weighted sequence, and this is the epidural fat. It's a fat is bright on T1, so that's what that is. Sometimes you can get marked overgrowth of the fat, epidural lipomatosis, and then cause actually spinal stenosis or narrowing of the thecal sac. So that's the epidural fat, and then here is which of the following structures being pointed out by the arrow in case 3. So is it the posterior longitudinal ligament, facet joint, ligamentum flavum, or dorsal nerve root? So this is the ligamentum flavum. So remember that when you get spinal stenosis, there's lots of ways to narrow that thecal sac. You can have a diffuse disc bulge. You can get facet overgrowth. Here's a facet. You can get ligamentum flavum hypertrophy. You can get epidural lipomatosis. And these are all different ways to get narrowing of the thecal sac. And that's really what the heart of spine imaging is, to see where those nerve roots are affected. So remember that that's the ligamentum flavum. The next question is which of the following structures are being pointed out by the arrow? Well, the nerve roots within the thecal sac are the cauda equina, and the cauda equina nerve roots will be within the thecal sac below the tip of the conus, which typically is at the L2 level. And you always want to look at abnormal enhancement of these the cauda equina nerve roots, especially in the setting of leptomeningeal spread of disease. And then the final case set here is temporal bone. So which of the following structures being pointed out by the arrow? So here's a pretty straightforward question. The internal auditory canal, remember it contains 7th and 8th cranial nerves. 7 up, coke down is a useful mnemonic. 7 is the facial nerve. Cochlear nerve is the anterior inferior. And then along the posterior aspect, you have superior and inferior vestibular nerves. Typically, you can get expansion of this, and you're dealing with vestibular. Basically, you're dealing with the schwannomas in this location, previously called acoustic neuromas or vestibular schwannomas, you could say. The next question here is which of the following structures being pointed out by the arrow. So here's the cochlea on axial imaging. So basically, you want to note a couple of points. First of all, that the cochlear nerve has this little aperture, which is called the cochlear aperture, and then you can probably faintly see this little bony strut in the middle extending from the central to laterally. That's the medullus, which houses the cell bodies of the spiral ganglia. And then notice you then start to see the middle and apical turns of the cochlea. Remember, 2.5 turns of the cochlea. And then you always want to look at cochlear morphology, especially in the setting of pediatric sensory neural hearing loss, because you can have sort of common cavity deformities or aplasia of the cochlea, things like that. So remember to look at that, and then which of the following structures is being pointed out by the arrow. So looks like majority of people got this question. This is the posterior semicircular canal. So remember, one other point is kind of in this image you also see the vestibular aqueducts, which are actually important structures to identify. They're those J-shaped structures that emanate from the posterior wall of the petrous bone and then extend into the vestibule. You can see enlargement of the vestibular aqueduct in the setting of people can get fluctuating sensory neural hearing loss when they have enlargement of that. And it's important to identify because they're advised to stop contact sports as a precautionary measure. But the correct answer in this case is posterior canal and then the vestibular aqueduct just next to it. And then the next question is, which of the following structures is being pointed out by the arrow? This is the lateral semicircular canal. So remember that here's your vestibule, then you have this lateral canal extending from that. The other thing to note is there is actually this little bone within it. It's called the bone island of the lateral canal. And then also note that the facial nerve, so the facial nerve has 5 segments. It's got a cisternal segment as it extends from the brainstem, then an intracanalicular segment, a brief labyrinthine segment extending to the geniculate ganglion. And the tympanic segment runs posteriorly and inferiorly, and there's a constant relationship between the lateral canal and that tympanic segment because it's going to run along the undersurface of that. And then the last segment is the mastoid segment. So 7th cranial nerve anatomy is important, and also remember this relationship. And then the last question is, which of the following structures is being pointed out by the arrow? And that is the vestibule, which we talked about. So basically, you again see the lateral canal, bone island, vestibule, etc. So, and I guess that was the last question there. So let's see if hopefully that was a useful presentation for you guys. Remember, anatomy is... Hello?
All right, Narayan, we have the questions which we will go through now.
Okay.
And on your control panel, there is a strip called questions.
Right, I see that.
Now go to the right of that, your right, and there are 2 buttons. One is an X, and the other is a strange angle-shaped thing with an arrow.
I see.
Click on that.
Right.
And expand that window, and you can move that window around. We can't see it.
Okay, fine.
So Ruth has put in the flags on the ones that need to be answered. Those are the ones which are academic questions.
Okay.
Can you see the flags?
Yeah, I see. Case 2, question 1. I think that was the first flag. Is that a T1?
Excellent. Yes. Go with yeah. Just go through those questions one by one, please.
Okay, not a problem. Let me just show this from the current slide. View show. Case 2, question 1. So the question is this a T1 weighted sequence? Does the white matter look darker than the gray? Yeah, that's, I'm not sure if I said that. This is actually a flare sequence. I apologize if I said T1, but this is the flare, so he's correct. You can see that the white matter is a little bit darker here, and that's because flare suppresses CSF signal. The white matter is myelinated, so that CSF suppression will make it a little bit darker. So that is a flare sequence and not a T1. The next flag says, case 5, question 3, can you see optic, let's see, case 5, question 3, it says, can you see the optic chiasm? Let's see. Can you see the optic chiasm on this image? You cannot see the optic chiasm on this image. We're sort of at the dorsum cellus. We're just sort of kind of into peduncular cistern. Remember, this is where the third cranial nerve, so probably just a little bit above you may see it. And actually, think about it. If you have a cellular tumor and you get to, and the tumor, what they do is typically extend up, going into the supracellular cistern, and that's where usually the chiasm will be affected. So that's why those pituitary macroadenomas we see emanating from the cella going up, and then the surgeons will also always want to know when they're doing those endoscopic surgeries what's happening with the chiasm. So, but usually you can figure that out on the SAG and other sequences. Okay, let's see here. Case 7, question 1. What is the arrow pointing to? Case 7, question 1. What is the arrow pointing to?
I think it's the arrow A that they are asking.
Oh, arrow A pointing to. Well, it looks like they're just pointing to a portion of the frontal horn of the lateral. It looks like more like the roof of the frontal horn, more like the ependema. It wasn't part of the answer anyway, so it's not. It's not an area where there's choroid. Okay. Here's case 6. Apart from the right answer, can you tell us what are the choices C and D? Okay, case 6. Okay, so C and D, I believe C, let me just, how can you tell, apart from right, can you tell what are the choices C and D? So C, I think I mentioned was, so basically C is here's the pond, so this is the prepontine cistern, which is flanks both sides of it. I believe D is kind of actually pointing to the sort of the middle cerebellar peduncle / junction of where the cisternal segment of the 5th cranial nerve is going to exit from, right at the root entry zone. But the Meckel's cave is going to be here. Remember that the Meckel's cave is contiguous with the prepontine cistern, lined by dura. The flow void of the ISA is medial to that. So hopefully that answers that question. And then, let's see, one more flag here. Let's see here. Case 10. So the lesser wing of the sphenoid, is sort of here's a greater wing. The lesser wing has a sort of medially angulated portion. The body of the sphenoid bone is kind of like a bat. It actually has a sort of like central portion, whereas the body of the sphenoid, then it's got these two, this sort of wing, if you will, and then that's a lesser, and then the greater wing flanks that even outer. So, and the outer portion, the anterior aspect of the middle cranial fossa, usually is bounded by the greater wing of the sphenoid. And let's see here. Case 13, can you repeat the boundaries of the posterior cervical space? Case 13, okay. So here's the posterior cervical space. Well, on this image you can see that the posterior cervical space is containing at least portions of fat. Remember, accessory nerve is going to be there, but the sternocleidomastoid muscle has a portion that'll flank its lateral border, and then the paraspinal muscles of the perivertebral space will form the more medial boundary of that. Okay, and then where is the perivertebral space? I think I sort of got into that. The perivertebral space is, remember, peri means around, so around the whole vertebrae is collectively called the perivertebral space. You have a prevertebral and a paraspinal space. Probably not that critical to know, but it's more of a important distinction to remember. Case 14, what is arrow A? Case 14, let's see. Let me go to the question here. Arrow A, the genioglossus muscle. That's what the correct answer was there.
Go on to the other images of case 14.
Let's see. Oh, I
Case
see.
14,
Okay.
go to the other
Okay.
image. Yeah.
Let's see that. Okay. So A is just sort of pointing to the median raphe which is sort of just medial to the, it's just sort of this fat midline structure. This I guess just called the median raphe, genioglossus there. What are choices A, B, and C? Okay, so B is sort of pointing to a portion of the sublingual space there. C is pointing to the submandibular space. Remember, genioglossus, sublingual space, mylohyoid, submandibular space, platysma. Okay. So let's see. Is the thyroid cartilage at this level? Case 16. Case 16, question 1. Yeah, the thyroid, we do see part of the thyroid lamina.
For a moment? Yeah, could we go back a little bit? That previous one that you showed.
Which question?
Space.
Which question?
Oh, the previous one.
Sublingual space.
One. Which one was that? Case
15.
Case 14.
Case 14.
Yeah, 15 is fine too. Just tell them about that inverted V of the sublingual space and how it is divided into those two, where it is showing A and B, and just bring that out again. That may be important.
Okay.
In this case, in this image, the A and B, the A is the medial portion which has one nerve, and B.
Oh, right. So here's a genioglossus, and remember the sublingual space. The more medial and lateral components of the sublingual space are actually divided by the hyoglossus muscle, which is there, and the more medial component contains the 9th cranial nerve, glossopharyngeal, and the more lateral component contains the 12th nerve.
Thank you.
Okay, and then I guess we were on, can you go over, I think we talked about question 16, which shows the thyroid lamina. That is correct, they are there. Case 17, question 1, can you provide a reference for the chart? I believe that we can provide a reference. Maybe we can when we send it.
Yeah, I'll email it to you all. Yes.
Can you go over case 17 again? Okay, so case 17, just to remember about the stations of the head and neck. Submental and submandibular is 1A, 1B. 2 from the skull base to the 2, 3, and 4. 2 is kind of jugulo-digastric chain, so basically skull base to the inferior margin of the hyoid. 3, inferior margin of the hyoid to the inferior margin of the cricoid. 4 is going to be below that. So here on this case, you're sort of below hyoid, but above the cricoid, so this is a level 3 node. Here we're above the hyoid, touching the vein, jugular vein, so this is a level 2 node. This is a submandibular node with level 1B. And then here, remember, posterior to the posterior margin of the sternocleidoid muscle, level 5 nodes. So here's behind the posterior margin, so this is a level 5 node. And then this is in front of the posterior margin of the sternocleidoid, but behind the jugular vein, not touching, so this is a level 2 node. Okay. Now we were on case 18. Can you show the choices again? Sure. So anterior atlantoaxial membrane, apical ligament, tectorial membrane, cruciate ligament, or transverse ligament. And the correct answer is tectorial membrane, contiguous with the posterior longitudinal ligament. Case 19, in which scenario would the, okay, case 9, in which scenario would the L4 nerve root be involved? Well, if you had a, first of all, you can have a, if you had a paracentral disc protrusion, for instance, this is more foraminal, but if you had just a small disc protrusion here, you could affect the traversing right L4 nerve root. And then could he review, okay. And so the last one said, review 18 also with the enlarging MRI images. Let's see what that's about.
Yeah, just make this full, your PowerPoint as a full screen. That should enlarge it. Just double click on it or on the top. Yeah.
Did they say case 18 or case 9? Let me just see.
No, case 18.
Case 18, okay. So we'll just start from the beginning there. So remember, I hope this is large enough, but posterior longitudinal ligament, tectorial membrane. Here's that apical ligament. Here's the anterior longitudinal ligament flowing down. Cruciate ligament, transverse ligament. You can't really, you can see part, can't really see the entirety of the cruciate ligament. You know, it's going to be just, a part of it is going to be just deep to the tectorial membrane, and then it's going to have transverse portions emanating from it. So that's that one. And I guess hopefully that was, okay, great. I think that was pretty much it.
Also, go over the question 2, case 18.
Oh, question. Oh, okay. Question 2 was just pointed out to
same thing, yeah.
Anterior longitudinal ligament in case, and this was the apical ligament.
Okay. And then on case 16, last question, can you please point out the cervical fascia? Now, what's that about? Let's take a look.
Case 16.
Yeah, that last question.
Sorry.
Case 16, last question.
Yeah, you know, we don't actually see these fascial layers routinely on the imaging, so it's not something that I could even point out. I mean, there are boundaries between the superficial and middle and deep cervical fascia, but the main point of this question was just a platysma.
Excellent. I don't think there are any more questions. Ruth, all yours, please.
Thank you so much. And Dr. Viswanathan, thank you so much. What a great job you did today.
Thank you.
You work well under pressure. For everyone else, let me remind you that at 2 o'clock today, Dr. Attili will be presenting cardiac for my interactive enrollees.